get it on or?
Yeah, so I would want you to please distribute the healthy school certificates to all our speakers, please.
Okay. Yeah? Before the question and summing up?
Yeah, we'll have that before.
Please go ahead.
So I would request everybody that we have a minimum time of 15 minutes, please. Everybody can please come up with their questions. We have our 4 mics there arranged right in between you people. So please make use of them and please come ahead with the questions.
Are we waiting for questions?
Yeah.
Can I just sum up before we start?
Sure.
Okay. I think that before we go home today, I think the message to take home today, at least what I got from the presentations this morning, was first and foremost they were all outstanding. Every one of them addressed a very clearly enunciated, very specific area of concern. And we started off first with the premise that technology cannot be just used for its own self, that it has to really be directed towards a purpose. And the end use of technology, particularly in healthcare, is far more important than the technology itself. And we saw 5 very dramatic examples. We began with Dr. Chowdhury, who showed us that in a milieu where skills are extremely in short supply and skilled people are almost impossible to get, how can you use adaptive technologies, how can you use appropriate low-cost technologies to be able to substitute skill givers with other technological solutions that can provide the same kind of answers that we're looking for. Dr. Dakal again showed us in a very, very remarkable way that home care is not essentially discounted low-quality care, that home care is possible using today's technologies, portable technologies, to provide very sophisticated levels of care to end users in very remote and difficult situations. Dr. Anjali Mishra again showed us a very, very valuable lesson in the sense that follow-up of patients, which are so critical, especially when you're dealing with diseases that have to be followed up almost for the life of the patient, can be facilitated to a remarkable degree and can be made so much more efficient with the use of telemedicine. Rajagopalan gave us an absolutely brilliant demonstration of how it's possible to leverage and to recruit entire populations of relatively low-skilled individuals to perform a very, very valuable task with some few short, effectively done mentoring sessions and monitoring. That was a great lesson. And then, again, I think Anita kind of summed up the whole situation by saying that that there is a need for long-term evidence in terms of a lot of what we do, and I think that in that regard, again, most of us need to pick up the slack. We are now open for questions from the audience. Once again, how much time do we have?
15 minutes.
15 minutes, okay. And again, brief questions. And if there are comments, please keep them very brief from the floor. Please announce who you are and whom you're directing the questions to.
I wanted to know, how do you set remotely for the patients whom you want to make an appointment for the telefollow-up? Because as I'm aware that we'll be decongesting at the main hospital, but how can we assess those the follow-ups? How are they done remotely? Thank you.
I have shown so far as this particular project was concerned, this was done in consultation with the telemedicine center which is already established in Cuttack. So Cuttack is some 1500 kilometers from our hospital, and our hospital is connected to so many telemedicine centers. So if the particular center is consenting for the same, we give an appointment we ask the patient to seek an appointment from that particular center, and we have a particular day and time fixed for these teleconsultation. But obviously our center being a tertiary care referral center, we do have a very limited number of patients for limited number of diseases. So whether the same model can be applied to general population or general kind of diseases, I cannot say. But as this thing, at our School of Telemedicine and Bioinformatics, we have, especially the thing Dr. Mishra is there, he would be able to tell you that we are taking this facility forward, and nowadays this thing, patient, particularly new generation is so much comfortable with technology. We are taking it forward with Skype technology, and other form of this thing, tools would be offered to the patient in future as well.
Thank you so much.
Shoulder the responsibility to look after or to monitor. In your case, you said you sent a senior resident to the Department of Telemedicine, and possibly that connotes that you do not go yourself, you send your senior resident. The day your senior resident is on leave, is there any alternative arrangement done so that the patients who are actually waiting in the Cuttack, who have come all the way from Odisha, are they looked after? Is there some arrangement which you...
Taking care of my patients. So since it is not private hospital, it's a university college, somebody would always be there to take care or shoulder my responsibility in my absence.
Okay, ma'am. The second question is, as you mentioned, it's not a private hospital, it's a government hospital. Obviously, the person who's answering the question is not getting paid. Is there the same amount of interest to the queries of the patients, which patients generate in their own general non-medical lingo?
And psychological concerns also.
You on your telephone, rather than you sending a senior resident oblique anybody else to the telemedicine center and calling the patient at Cuttack in telemedicine center from Odisha, different parts of Odisha, isn't it be more feasible to just answer that question on your own mobile number, whether it is a 2G system or a 3G system on your mobile? More easily you can answer and directly you can answer. Maybe your time consumption will be little more, but that is what you're also doing by sending your senior resident to the telemedicine center. So I personally feel giving your personal number would have benefited much more, which I am gradually going to implement in my center. What is your say on that? Ma'am, that is the amount of cost we as a...
Yes, actually this, apart from telephonic conversation, it is well established that whenever there is a telephonic conversation, there may be misunderstanding about the patient's problem, the doses which medication which we utter, the doses about those medication, that is a, and when we are using this thing, it's not only interactive conversation, it is a store forward kind of listening facility also. The patient is sending his or her report and we are sending out prescription in written form. So that is a legal document as well, that on that particular day I have seen that patient and prescribed him or her those particular medication. And apart from that thing, patient always have a psychological kind of good being or well-being looking at their doctors.
Thank you, ma'am. Thank you. Point well taken. Thank you.
Yeah, we could move along.
Because what it is it's showing the evolution of telemedicine from what we used to do, which is a point-to-point connection between two centers, to the need to evolve a many-to-many, which has a potential to first triage. So you understand what they really need, to connect a generic call center which is manned by doctors, a specialist telemedicine option which does not necessarily need to be in the telemedicine room. And the day when the doctors can see virtual patients as well as patients in their OPD almost continuously or concomitantly, because you're moving it through that. So this is the process of evolution from a point-to-point telemedicine to an integrated telemedicine which has phone, SMS, fax, email and the video conferencing, all based on a common scheduling system, a triaging option and a health record. And that's when you start conceiving your telemedicines like that, many of these things will get sorted out automatically. The issue of being rude, that needs a different kind of handling. I'm sorry about that one.
The policy making bodies to take a note of this particular session, which is devoted to the clinical applications of telemedicine. The speakers spoke of variants of application in telemedicine. Some of the comments I would like to give, which is very relevant for policies. Now, one thing is Dr. Rajgopalan, Suresh Center in Chennai is very famous about that. The remarkable thing, besides being a good technician and his credibility in ultrasound, especially in fetal medicine and fetal genetics, etc., they establishing the training centers. You will find plenty of good technologists, skillful surgeons and physicians. There are few who wants to give that technology skill to others. This requires a magnanimous and a very large heart to have this kind of aptitude. I must appreciate and congratulate the center and particularly Suresh for taking the initiative. Now the message that I want to Dr. Dhamija here from Minister of Health to take a note of it. The network, the infrastructure that the ministry is going to lay down in the country, riding over the NKN, that is the multi-gigabyte optic fiber network, cutting length and breadth of the country, and the vision that this government of India is going to see the applications built on this. One of these applications is developing skill in the rural most physicians or caregivers, that is the PSC, Primary Health Center physicians looking at the pregnant lady. Now, can we have this kind of application into our NKN application grid that we are going to develop for telehealth, going to the NOFN, National Optic Fiber Network, which is going to reach to the Gram Panchayat level, 250,000 Gram Panchayat levels. The second part I want to know, all of you know the Millennium Development Goal 2015 we are supposed to meet the target. I think this target is getting shifted. We cannot achieve, especially in countries like ours or any other developing countries. One of the criteria is the mother and child goals. And look at it, without a skilled ultrasonologist, we cannot achieve that because hundreds scores died because of the lack of recognition and lack of the care to be delivered or lack of recognition of the high-risk pregnancies. So here lies the serious effort. This needs to be translated and expanded to large horizon. The second point I want to share is again a comment.
So there are a lot of people waiting.
Just as a brief comment, just appreciating, just one, give me 2 seconds only. It's a Kathmandu, there's no question for mine, just a comment.
There are others waiting in line behind you.
I'm sorry, just 2 seconds. The Kathmandu experiment is very much educated to all of us, and the Bhutan experiment is also very educated to all of us, where the health call centers are in practice. And I request all of us to look at those sites, to look at what is happening in Bhutan and Nepal. Thank you for giving the opportunity.
Of all what has been commented upon from ministry perspective, I am Dr. Dhamija from ministry. Dr. Pandey talked about certain things. I just want to correct one thing. Dr. Anjali Mishra said that my senior, Dr. Mishra, who just spoke, not senior resident. Dr. Mishra is one of the pioneers of establishment of telemedicine in the country. Anyway, number 2. Ministry has been focusing more on IEC earlier for education point of view, but we have now taken notice of IPC also, and we are doing a lot of work on IPC. But there is an urgent need which we felt last year about behavioral change communication. What Dr. Pandey mentioned about the response from the government sector, I tell you honestly, response from the private sector also many times is like this. एक बार बोल दिया ना, कितनी बार बोलेंगे, because they are also busy. Second thing is, they are paid. The government doctors are also paid by government, but the change has to come from within, which government cannot enforce. That cannot change the people talking how they want to talk. It is all of us, we have to think about it, but still, Government of India has taken initiative of BCC, that is Behavior Change Communication, not only from the perspective point of view of service providers, from the perspective point of view of the service takers as well. So these are all points well taken from the conference. And the second thing is that whatever Dr. Anjali Mishra explained about the thing which has been done, scheduling will be done, what Dr. Mishra commented upon. This is going to be a nationwide rural telemedicine network project, which I will explain in the next panel when we come up on the stage. But all these points which have been evaluated in the last 3-4 conferences have been well taken care of by the ministry in the next planning and implementation program. Thank you.
Bhatia, Director CDEC Mohali. I have 2 points. One is the ongoing discussion, which is Dr. Mishra and Dr. Dhamija has already talked. Basically, the question is to send the parameters related to the health of a patient to an expert or to a doctor so that he can have a look at it and advise. This is basically required. Media, how it is done is not a question. So having a laptop, having a mobile, iPhone, whatever it is independent of it. It is the inventions which will come in between where the applications will be developed. That is there. My question is basically to Dr. Chaudhary that you have said low cost. Every equipment which is you have mentioned is low cost. It's a very, I work in this field. I have developed a lot of equipment in this. But this word is not acceptable because low cost is even parallel to the highest cost. What kind of low cost you are talking about? What is the range? Say your SpO2 and heartbeat.
Yeah,
how much it will cost?
This is prototype that we have designed practically for the students. So students have purchased red LED, infrared LED, and photo detectors, and we have interfaced with our red LED and 10 rupees on infrared LED and hardly 20 rupees on photo detector. And we have interfaced this with our deck, available NI deck. It's quite cost effective, this prototype.
Are these wireless?
Not wireless, is wired. We can, I can show you, I have a hardware available in my bag.
Okay, thank you.
Well, our questionnaire said great passion. Thank you so much. But before that, as informed before, Apollo runs a campaign of healthy schools where Apollo sponsors the underprivileged schools. And last week we had 4 of such schools which were sponsored. The kids and the parents are given free insurance, free health insurance. And we would like you to please accept the token of thanks from the school. Can I have the certificate, please? Please greet them as speakers with the certificates, please. Ms. Sangeeta Reddy, who is the Executive Director of Apollo Hospital. May I please request ma'am to please come on stage. And on our panel list, we have Dr. Sunil Gavaskar, we have Dr. Navneet Kumar, we have Dr. S.N. Sarambhadikari, and I'm sorry for the pronunciation, and Dr. Saroj Mishra and Dr. Bhatia. I would request all our panelists to please come on the dais. Ms. Sangeeta Reddy is an Executive Director at the Apollo Hospitals. Ms. Sangeeta Reddy leads the human resources and IT functions across all divisions of the group. Ms. Reddy inputs are central to the structure and values of the Apollo culture. She has been instrumental in exceeding community-based hospital projects with a special focus on rural areas. The agenda of this panel discussion will be the government initiatives. On our panel list, we have Dr. Sunil Gavaskar. Mr. Gavaskar is an anesthetist by qualification. Currently, he is a part of the Health Management Information System and is facilitating the development of applications and assists government hospitals in Tamil Nadu. We have Dr. Navneet with us. Who is the Deputy Commissioner for Training and Telemedicine in the Ministry of Health and Family Welfare in Government of India. We have Dr. S.N. Sarabadikari, who is the Project Director of Central of Health Informatics of the
Powerful panel. Everyone you see here has the ability to change the lives of many people in the healthcare sector. And I think that's what we were trying to do. By putting up this panel is to begin to have an understanding for people from the private sector to really get insights into the tremendous progress that's happening in the government. All of you here know that the budget allocations for the health ministry have increased tremendously. Actually, over the last 3.5 years, they've more than doubled. But interestingly also is the increasing awareness of initiatives like telemedicine, like electronic health records. Tamil Nadu, I think, has an extremely smart procurement system. So there are different areas. I want to apologize on behalf of the Andhra Health Secretary. As you know, there's a little bit of thing happening in the Secretariat, but he has promised to find a way to come in sometime during the day to share his comments and to meet with all of you. So what we're going to do is, the idea was to have no presentations, to make this extremely interactive and more like a dialogue. We have one presentation which we will do immediately after we have a few comments from each of the panelists. So I'm going to request each of you to please share what you're doing, what your ministry, what your division is doing, and how it will impact people sitting in our audience. Once we've done that, then I'll request you, Dr. Gavaskar, to share your presentation. Can I start with you, Dr. Mishra?
After the facilitator for my distant education initiative to spread the surgical skill in the field safety. Since then, I have been involved and seen the growth of telemedicine, and now I must say that we have reached at the almost nearing peak. Actually, I must like you, Sangeeta. This is the time actually we must really hit the iron hard. Last time we had a Cyberabad declaration here, and we have all placed that wherever we are, in whichever little way, we must contribute to see that IT is incorporated into the healthcare, education, and professional skill development. We are seeing light of the day. Some of these declarations, I think Dr. Hamida will say that ministry is doing. And there are few people who are here in this hall itself who are taking policy initiatives and helping the government to shape the policy of e-health in the country. What has happened over the last couple of years, more than 10 years, that telemedicine has lived in this country. Many of these leaders are here. Ganpati you have seen here, Sangeeta is here, and many others are here. They are from R&D institutions, Mr. Bhatia. Many of these people from the ministries after the annihilation of the constituted has taken real big role in adopting telemedicine in larger context, IT into healthcare. The major thing that has happened here actually in our country is that many of the centers of excellence has come up, both in the government as well as in the private. And Apollo has led the entire bandwagon in the private sector, and more of them are being followed by the MAX, Fortis, and many other institutions. We have technological trends and developed technology in the country itself. It is our technology made in India for Indians. And these products have a lot of potential to go to developing country. And there is need for government to take a note of this thing and help these developers to create a platform internationally. Frank Levins is here. All else have been trying for the last so many years to create an Indian platform in the medical event in Luxembourg. Just because they are not getting support from the government so that we can support, take this industry. So India has led in production of the IT equipment, IT processes, defined how the system should work, and also the centers of excellence have developed. We have expertise. We have centers who have shown the way how the telemedicine can go for a national level applications, transformation both in the government and private sectors. What is lacking in our country now is, of course, we have a concrete policy on the e-health and strategy. Of course, that Dr. Hamida is going to tell you about that thing. And there may be budget, but unless you have a clear-cut strategy and policy, I can't say that it's not there, but there are still some of these gaps to be filled up to define that government means business in telemedicine. And with that, I just hand over the mic to Sangeeta to take it forward.
So thank you, Dr. Mishra. I think that I'm going to request the speakers that we do 2 minutes talk about programs which you have seen under your control or that you see a colleague doing who's not represented on this panel. We'll go really brief because in the course of the discussion I think we're going to really hear a lot from the audience. I'm extremely happy that you're here, Dr. Tamija, and request you to please take it.
Yeah, I like the comments from Dr. Sangeeta Reddy that I talk about national program initiative in 2 minutes. Very difficult for me. What's formed the people that Government of India has taken 3 major initiatives. First is the National Knowledge Commission of Government of India has provided National Knowledge Network. In short, we call it as NKN. What it means is basically a high-speed bandwidth connectivity, 100 Mbps and above, to the extent of 1 Gbps also, to all educational institutions in the country. And when I say about my health sector, it amounts to medical colleges, which are the educational institutions. Then, to the private sector, it means that the Government of India has provided free high-speed bandwidth connectivity to all medical colleges. I'm talking about health sector now. Then the initiative which has been in process, already in operation, has been SWAN, that is SWAN, Statewide Area Network. Since the demand earlier was low, the speed was 2 to 10 Mbps, but now it is scalable to 1 Gbps. It's ultimately something like that. The pipe is there, how much water you pump in. The third initiative, now that SWAN initiative gives you connectivity from the state level to block level. So for some people who don't know how the health sector functions, It is like there is a central government, then there is a state government, then we have reaching to the districts, we have district hospitals, then we go on below down to block which has community health center, in short we call it as CHC. Then we go further down below into the primary health center which cater to somewhere about 5 to 6 villages. And then we have sub-center. So sub-center, which is a village level service, primary health center, which has a medical officer. The sub-center does not have a medical officer, it's manned by A&M and other staff. Then we have got community health center, which is a large bedded hospital. Primary health center may be 10 bedded hospital. This is 40 to 60, 80. We have sub-district and district hospitals. Then we have got state hospital and medical colleges. Now, to me in health sector, my internet bandwidth connectivity with a high speed has reached block. The third initiative of Government of India, which is called NOFN, this is National Optical Fiber Network. Again, a very high speed assured 100 Mbps bandwidth connectivity to every Gram Panchayat, means it is reaching the village. From village, Gram Panchayat office, if it is PHC or center is near, health facility is nearby, it's okay. Otherwise, the last mile connectivity will be given by the local provider. To me, in health sector, it means now my whole country with 250,000 villages will be connected with high-speed internet bandwidth connectivity. How can I leverage it? The ministry, when I say I, does not mean Dr. Dhameja, ministry. Ministry is leveraging this initiative to start basically 4 initiatives. One is National Medical College Network, wherein we are bridging, connecting all national medical, government medical colleges to begin with, private will follow, to have tele-education, have digital libraries set up, so that we can have education to every medical officer and everybody should be at par as far as knowledge is concerned. Is that the basic objective? No. Ultimate basic objective is teleconsultation, tele-follow-up, so that the real user beneficiary at remote area can have expert consultation. The first initiative is to let everybody become an expert. The individual capacity will be different, but the knowledge part. Then the telemedicine network will be to give telemedicine services, telehealthcare services to the remote areas where doctor cannot reach. So the goal of reaching unreached, part of universal health coverage. And the third initiative would be mobile health, using mobiles, applications on any gadget available nowadays, as well as sending the mobile vans with dish satellite antenna ultimately to connect. Now, these are the initiatives which Government of India is going to take care of in due time to come. This is what I wanted to convey. Details will be given to you. You can have access to the websites. All websites are available. I request Dr. Mishra to give you more details on this because he has got a subject to speak on this. And the CDAC officers are developing on the software parts in various areas. And that is how the Government of India will ultimately assure healthcare delivery, education and services to country.
Thank you so much, Dr. Nita. Years ago, I went to the Ministry of Health and spoke to Secretary, the Union Health Minister, everybody about this concept of an electronic health record, about the need for standards to be unified in the way we capture data. And the ministry at that point of time told me that we're more interested in the TB and the polio program. Don't talk to me about these standards in electronic health record. We don't have computers right now in every center. It doesn't concern us. But not to be, kind of put off by that, we actually went to the Ministry of IT and worked on the first project called Health Unite, which created the first set of standards. Dr. Mishra was part of that working committee. At that same time, we brought out the very first policy on telemedicine and telemedicine standards. Subsequent to that, I think those of you in this room who were party to the last year's conference, the Cyberabad Declaration had as the first point in that conference And our Chief Minister, Honorable Kiran Kumar, actually proclaimed that Cyberabad Declaration, signed on it, Sam Petroda signed on it, and finally this was handed over to our Health Minister. But the beauty of the thing is that the awareness levels in the ministry are so high now that within these 12 months, the intervening 12 months from the last conference, a working committee was created on standards for electronic health records with 4 subgroups. Mr. Jain, R.K. Jain, who is the additional secretary chairing that, has also invited Mr. Desi Raju in for the last meeting. This committee has got the buy-in from all the medical associations, including the IMA. And IMA sent back, they created a subcommittee and said we find these standards accurate, comprehensive and applicable. But don't make it mandatory to apply, but we'll start adopting it. So I think we've really covered some major ground in that front. And you have one speaker, Arvind will be talking about it, he's a member of the subgroup. With this, I also want to say that every time we're in the ministry talking about connectivity, CDAC is the name that comes into fore. So I'm extremely happy that Mr. Jagjit Bhatia, the ED of CDAC, is here. Dr. Bhatia, would you please share some thoughts?
Telemedicine, first of all, I will tell you, we started this project. We started this project in the year 1998. I joined CDAC during that time, and the first project was started, where we have a national network of big institutes like PJ Chandigarh, PJ Lucknow, and AIIMS, and that was installed a product called Sanjeevani. That was a client server-based product. Then we go on, and the next product was eSanjeevani, which is web-based. Now it is installed on cloud, which is available through the world. At this moment, we have completed a good number of projects, like National Network, E-Panchayat in Rajasthan, like that, a good number of projects. We have more than 100 plus installations. The latest is NOFM, where the government has asked us to put 3 pilot stations, which is installed and working. They will be inaugurated very shortly. This is what is there. Now coming to the cloud, which is talked a lot in the previous presentation. Our software is already there. Anybody can use it with the permission. But the question is, it's not only software which is required in the cloud. The telemedicine consists of communication with major medical equipment, and then the software. I have seen a lot of software, and I think we have reached a maturity. No doubt, software is never complete. It is a going on process. But it has reached a maturity where we can go on, that's fine, but it is acceptable. Then we need hardware. Hardware can be used by patient directly, which is missing part, because most of our devices are invasive. We need non-invasive devices where a person can wear it and its parameters can directly be reported to the network where doctor can have a look at it, which is amazing. At our place we started hardware also, where we have recently built biochemistry fully automatic biochemistry analyzer, which is of almost 1/3 of the cost, which is, I would say it's not low cost, but it is of 1/3 of the cost of similar type which is available in the market. Similarly, we have got digital stethoscope, which is hardly of any cost. Then we have dermatoscope, which is, I think, will cost also 1/3 of the cost, for which the similar type of is available. They are already there. We have requested, and Ministry of Health has agreed that they will be getting it tested and certified. Similarly, a lot of other ones like ECG, wireless ECG, just hear it. Wireless ECG will come on your mobile. You can pass it on, or even doctor can have a look at it. These are the devices which we have. The third part, one is software. hardware. The third is everywhere, which is a new one, which requires a lot of research from innovators. Means why a device should be sent to a patient. Devices should be on the cloud and patient should be on the net. Through communication, the device should be able to get the vital parameters of the patient. This is the ultimate where we are working. We want to work on this so that we can get give the public a good, because we are government of India. We have no personal or business interest or anything, but we want some good innovation from our side. So with these words I will say thank you.
Thank you. Other initiatives which are being undertaken, and I'll request you, Dr. Dhameja, like you did earlier, what is the initiative? How do people see it alive in the field, and how can the private sector relate to what's happening?
Ministry has a secretary to government of India, and has a family welfare secretary. Then every joint secretary, after the additional secretary, joint secretary is given the charge of the whole segment. The joint secretary in charge in my ministry for telemedicine is Dr. Vishwas Mehta, and I bring greetings to you. He had to come, but because of certain occupation, he could not come. So I am representing. Well, in ministry we have administrative level joint secretary and the technical. I am the technical level, he is the administrative level. See, the issue is earlier, as you mentioned, Dr. Sangeeta Reddy, that initiatives were discussed, but then they said, wait, we have TB and we have all those difficulties at hand, right? Now we are facing three burdens today. First disease burden is communicable disease, which are not yet gone. The second burden we are facing is non-communicable diseases. Diabetes, hypertension, malignancies, cancers, arthritis, etc. The third disease burden is paucity of the specialists and the doctors available to cater to the healthcare delivery system. Taking all these factors into consideration, the ministry has taken now a very strong view and now has dedicated officers for different initiatives. Telemedicine is Vishwas Mehta and me. E-governance is another joint secretary and technical people in statistics. EHR, EMR is separate dedicated person, like that. So we have got 6 initiatives in the ministry being managed by joint secretary level and the technical officer level of the same in the ministry, looking after these initiatives. EHR was developed in USA, and today they have more than 1500 softwares, because every hospital started their own and they are not interoperable, they are not talking to each other. So everybody was talking about the idea that you are far behind, you don't work, you are so bad. Ultimately what we say is that whatever we do, we will like to do with the best to begin with. So we have initially developed standards, they are on website and they are going to be notified very soon, maybe another few days time. It is a government formality going on for notification, maybe another 7 days or 15 days we will have standards. Every government sector and private sector will have to follow those standards, so that the patient going from Apollo Hospital to Medical Institute, AIIMS Delhi, going to even Bhubaneswar, his record will be available, retrievable, talking to each other. Unlike other developed countries who are developed but not yet, interoperability issues are there. These are technical problems which are not, but I am trying to tackle those things right away. The second thing we are aware of is big data which is going to be generated. So I am taking care of that future complications expected to come very soon. So we are going to expect somewhere about zettabytes and yottabytes data coming up in the future, and we are going to take care of that. That is what we have already started thinking of.
Extremely exciting initiative of the Government of India. Actually, those of you who were with the conference last year and the year before would have heard Sam Petroda talking about it. And every time he saw me, he would always say, Sangeeta, what's happening about portal? And I would say, sir, I don't work in the government, I'm trying. But I'm extremely happy that now there's a dedicated department or a sub-department. The head of the national portal project is Mr. Sarvadipani. They have a budget, they have an initiative, they have a plan, and they have a potential launch on October 2nd, which we're all keeping our fingers crossed that at least phase 1 will be launched. Please share your thoughts with us.
Yeah, National Health Portal, I'll talk about another recommendation of the National Knowledge Commission. In fact, it was called something like National Health Information Authority, or NHIA. That entity is yet to be formed, but I think time has now come for that to be formed. So one of the things which India is sadly missing, we don't have a national e-health strategy. Even much smaller neighbors of ours are having it, but we are yet to formulate it. And WHO has actually got a national e-health strategy toolkit. It's not a big deal, but then we have to probably sit together and see how it is done. And once the National Health Information Authority is in place, the national e-health strategy can definitely be their prerogative. Similarly, the National Health Portal right now it is being hosted at the National Institute of Health and Family Welfare. And another initiative which is very important and which I think will be applicable to many of the people sitting here in the audience. India, the Ministry of Health is actually going to procure the country license for SNOMED City. And this will be managed by the CBHI, the Central Bureau of Health Intelligence, as of now. But then for having that country, yeah, LOINC is free, so LOINC is not a big deal. But SNOMED City is quite costly. And for SNOMED City, you actually need an NRC, the National Release Center. So probably once this NHIA comes into being, then it can also be logically the National Release Center instead of CBHI. So these are some of the things which are in the pipeline. The other thing which I am going to talk about is the National Health Portal. Yes, we are planning to launch it in October. It won't be 2nd October, but definitely we are trying our best to have it in launch in October this year. And initially, it may not have a lot of things, but it will certainly be interactive and dynamic, and the real knowledge base is from you. So we would actually encourage lots of user interactions, and we would solicit your expert help in that. Because each of us, in fact, one of the things which is happening in patient care now, it's becoming more patient-centric rather than doctor-centric. And the information that can be gathered from the patient and the patient party is extremely important. In fact, there's a term now coined for that that's called actionable information. So the information that you gather from the patient or the patient party, and then how can you change the action so that the treatment is better, the management is better, and the patient satisfaction is also much better. And the National Health Portal is supposed to be this single point repository. I mean, it's a starting point. Whenever you need any information related to health, you start with the National Health Portal. You come there, and even if you don't find the information there, at least you know the right place, where to go, where to find the information on it. And as I said, I mean, it will also be very important for each of you to contribute. Thank you.
I'll request the National Health Portal is being developed in a subdivision of the Ministry of Health, that's the Ministry of Family Welfare, Maternal Family Welfare, and Dr. Neja would add a few comments.
Well, this is National Institute of Health and Family Welfare. This is a premier training institute in the country, autonomous body of Ministry of Health, which I am in charge of ministry level. We have already a website operational for the last 5 years, known as www.healthyindia.org.in. The basic idea was to give health education to masses, to do some IC on this website, have some questions, answer sessions, etc. Twitter and all those things, what I will discuss in the social media in the morning. That site is already operational. The second thing, we are developing National Medical College Network, which also will have a National Health Portal from the perspective of education, where all the national resource center at SGPGI Lucknow, headed by Dr. Mishra, and all the regional resource centers and other medical colleges will have content development bring into that. So that will be a pure tele education site, and ultimately I am planning to merge the healthyindia.org to allot separate tasks to it and the National Health Portal at National Institute of Health and Family Welfare. We are just looking at the server where we post it, whether NIC government server or wherever. Whichever server we are going to put it into finally, that will be the launch date. Then we will see what all education material and what all details we have to put into this site. A lot of things have been developed already, and very soon you will be seeing all these sites to get all education, all awareness about government initiative, various other material on health available from the user perspective as well as educationist perspective on these sites.
Thank you so much, Dr. Taneja. Dr. Sunil Gavaskar will now present. Can we have the slides, please? All of us know that Tamil Nadu is typically ahead of the game on the IT front as well as the implementation. And I think the health ministry in the government of Tamil Nadu has proved that they have initiated, but not just the development of the programs. I believe that they get a tremendous thumbs up for the implementation of some smart IT. Dr. Gavaskar, looking forward to hearing from you.